families. We're almost hitting the bench of 300. We started with around, I know my son was 39 when we started the foundation. We had maybe around 75 families. And now we're almost up to 300. And we're working on adding related diseases like KAT6A and other related syndromes. So I will start by introducing Dr. Fahrner. Dr. Fahrner, she's the director of Epigenetics and the Chromatin Clinic, and she's assistant professor of genetics and pediatrics at Johns Hopkins Medical Institution. And then Dr. Harris is also assistant professor of neurology, genetics, and pediatrics, and she's the director of Center for Tuberous Sclerosis and Related Disorders. So who's starting? Okay.
Hello, everyone. My name is Jill Fahrner, and I will be starting the talk. Dr. Harris and I have planned kind of a joint talk, so I will start and then she will continue. So I am going to share my screen. Oh, I actually don't, I may not be able to share my screen. It says disabled. The host disabled participants from sharing screen.
I think, yeah, I think you're able.
Okay, let me try again. There we go. That works. Thank you. Okay.
We don't see it.
Not yet. I'm still not.
We don't see it yet.
I know. I'm trying. Let's see.
No, now we see it.
We see it.
That work? Oh, great. All right. Wonderful. Okay. So thank you. First of all, hello to everyone. And thank you, Natasha, for that kind introduction. And thank you for inviting me and our team to speak tonight to the foundation virtually. We've been trying to hold a meeting, a conference or clinic, but because of the current COVID pandemic, it's had to be canceled a couple of times now. So I'm glad that we can at least meet virtually, and I look forward to when we can meet in person. So tonight, I'm going to talk about the molecular basis of KAT6A syndrome and some of the clinical features. And I'm going to explain how the disorder is a genetic disorder, but has epigenetic consequences. So the objectives for tonight are to introduce the concepts of genetics and epigenetics, to understand KAT6A syndrome as a genetic disease and illustrate how it has epigenetic consequences and why this is important for what we think is the basis for this disorder. To provide an update on the current knowledge of molecular changes and clinical features of KAT6A syndrome. And to introduce our multidisciplinary epigenetics and chromatin clinic at Johns Hopkins, where Dr. Harris and I see patients with epigenetic conditions. And then after my talk, Dr. Harris will talk, and I believe Clay Smith will also talk about his research. So I want to start very basic, and I just want to introduce some very basic concepts in genetics and epigenetics. So our bodies are made up of billions of cells, and each cell contains genetic material in the form of DNA. And the DNA contains about 22,000 genes. The genes determine our traits, so things like eye color, hair color, how we grow, how our brain develops. And each gene is a set of instructions or a code that tells our body to make a specific protein with a specific function. And so the DNA sequence or code is made up of 4 bases. We'll just call them A, T, G, and C. And genetics, the term genetics refers to this DNA code. So here I'm showing a schematic of the DNA, a couple of different genes, of which KAT6A is one of those, and then a zoomed out picture of the DNA code. When mistakes happen in the DNA code, these are called genetic mutations, and they cause disease. So mutations can be in the form of, I've sort of indicated it here with a big X, but they can be in the form of a missing base here, an extra base here, or an incorrect base here. And then that can lead to a variety of changes. Sometimes it can lead to a gene, a version of the gene that is shortened, or one that is really not made at all. But in general, these mutations lead to the gene not being able to function properly. And there are other types of base changes. So you can have sort of a misspelling in the DNA code where one base is changed to a different base. And that can lead to the gene not being expressed normally, but maybe still being there. So let me explain a little bit more about what I mean. So if a mutation occurs in the KAT6A gene, shown here by this X, then the cells cannot make the KAT6A protein, and that protein can then not do its job in the body, and that leads to KAT6A syndrome. It's important to remember, though, that we have 2 copies of every gene. And KAT6A syndrome is an autosomal dominant disorder. And that means that affected individuals have a mutation in one copy of the gene, shown up here, but the other copy is functioning normally. So the idea then is that what we think is going on is that KAT6A protein is still made, but there is less of the protein made. And so that is what we think leads to KAT6A syndrome. So what I've said so far, I just want to summarize to make sure everyone's with me here. So the DNA is the genetic material, and it contains our genes. Mutations are mistakes in genes that alter the DNA sequence or code. And mutations in particular genes, here KAT6A, cause disease. And here we're talking about KAT6A syndrome. But what is it that KAT6A protein does? So in order to get to that, I want to back up a few steps. Recall what I said before, that DNA is our genetic material, and it's divided into functional units called genes, and each of these genes determines specific traits. But our DNA is not just present alone in cells. It's actually packaged, and it's wrapped around these proteins called histones. And so the histones plus the DNA forms our chromatin. Histones are in turn decorated with these chemical groups called epigenetic marks. Here I'm showing those by these green hexagons. And the particular epigenetic mark of interest is acetylation. That's the mark that is disrupted in KAT6A syndrome. Epigenetic marks like acetylation are placed and removed by enzymes that are collectively referred to as the epigenetic machinery. So some of these are writers that place or write the marks. Others are erasers that remove the marks. And KAT6A protein is a writer of epigenetic marks, or a writer of acetylation. And epigenetic marks determine whether genes are turned on or off. So here, this teeter-totter is a schematic of a gene. And if there's acetylation present, that leads to this open chromatin and turns genes on. Whereas if there's no acetylation, these are called deacetylated histones, this chromatin is more closed, and genes within this type of chromatin are turned off. Any disruption in balance due to a mutation in a component of the epigenetic machinery, for example, KAT6A protein, can lead to disease. And when the mutation occurs in the KAT6A gene, the KAT6A protein or the writer does not function properly. And so too little of this mark is placed, and therefore the relevant genes are not turned on appropriately. And this leads to the disorder. But it's not just one gene that's affected. There are many genes we think are probably affected in KAT6A syndrome. And so this is just kind of illustrating the idea, which is that KAT6A mutations may cause KAT6A syndrome by disrupting this epigenetic mark and gene expression at many target genes throughout the genome. So here I'm illustrating a properly functioning KAT6A writer of acetylation. And this KAT6A writer, it activates or turns on genes 1, 2, and 3, but it doesn't affect genes 4 through 8. In KAT6A syndrome, where KAT6A is not functioning properly, these genes that are normally activated or turned on by KAT6A are abnormally turned off. And so if gene 1 is involved in growth, gene 2 involved in learning and memory, and gene 3 is involved in, for example, craniofacial development or development of the face, these are the processes that will be disrupted and the features that will result. So based on this, we think that KAT6A syndrome is a genetic disorder with epigenetic consequences. And one interesting and important thing that sort of comes from this idea is that we do have, in the future, we think that future treatments may involve correcting epigenetic marks at these target genes. So for example, if KAT6A, in KAT6A syndrome, you have this sort of tipping of the balance of chromatin or gene expression to a more closed state where genes are abnormally turned off, maybe in the future we would be able to restore this balance by treating with an epigenetic a drug that targets the opposite component of the epigenetic machinery and might normalize these marks. And these types of studies are ongoing for other related disorders, but we think that they might be applicable in the future to KAT6A syndrome. So in summary of the second part of my talk, KAT6A is a writer of epigenetic marks, acetylation. Mutations in KAT6A may cause genes to not be turned on correctly, and KAT6A target genes may determine the clinical features that we see in this disorder. And in the future, it may be possible, maybe in the distant future, to treat the disorder by correcting these epigenetic marks. So what is the purpose of all this? Why do we even have epigenetics and these marks? So it's interesting because we have the DNA is very complicated. As I said, there are 22,000 genes in our DNA. But every cell in our bodies has the same DNA. The same DNA code is present. Yet you can imagine that a brain cell has to do things that are very different than a heart cell. So how is this determined? How do certain genes get turned on and turned off in various cell types so that the cells can function differently in different tissues? Well, we think epigenetics plays a key role. Epigenetics allows cells with the same genetic material to turn genes on and off differently. So you can kind of think of the epigenetic machinery as the genome's highlighter. In essence, epigenetic marks highlight certain genes to be expressed or silenced so that our one genome can be utilized differently in different cell types. So for example, green genes might be expressed in brain, blue might be expressed in the bones, red might be expressed in the heart. And so in summary of what the purpose of epigenetics is, epigenetics refers to these marks on the DNA or proteins that determine whether genes are turned on or off. And epigenetic marks can highlight certain genes to be turned on or off so that our cells can function properly. So what then are the features of KAT6A syndrome? You all are very familiar with these probably, but just to kind of give an overview of the main clinical features of KAT6A syndrome. There are many neurobehavioral findings, which Dr. Harris is going to talk more about, but just to kind of list them, 100% of individuals with KAT6A syndrome, we think, have some form of developmental delay and or intellectual disability. And this is often speech predominant. We know that many have speech delay. About 3/4 have low muscle tone, about 39% have behavior problems, and about 9% have seizures. And this is based on the paper by Kennedy et al. And that was published in 2019. Also, many individuals with KAT6A findings have, with KAT6A disorder have eye findings. Many have vision problems, and about half have strabismus or malalignment of the eyes, where one eye might deviate outward or inward. And then many individuals have ptosis, where the eyelids do not open fully, either on one side or the other, or both. Many individuals with KAT6A syndrome have GI findings, or some of those include feeding difficulties. Many individuals with KAT6A have feeding difficulties. They can have reflux, and they can have constipation. And much more rarely, constipation can lead to bowel obstruction, which can be an emergency, or something that where the bowel can kind of twist on itself. So this is very rare, but if you ever notice an individual with this disorder having severe abdominal pain that came on suddenly, that's something that you should definitely have checked out and not ignore. About half of these individuals have congenital heart defects, and about half have frequent infections, and this could suggest an immune deficiency. About 37% have sleep disturbance, and a smaller number, but still significant, some individuals do have growth abnormalities. And the most common growth abnormality is a small head, or microcephaly, and that occurs in about 30% of individuals. Some children are born small for gestational age, but that occurs less frequently. Like many genetic syndromes, individuals with KAT6A disorder can have common facial features. This series of photos is taken from the paper published by Kennedy et al. In Genetics and Medicine last year. And you can see that the most common features of KAT6A syndrome are sort of this broad nasal tip, which you can see in many individuals, and a very thin upper lip. And those are kind of the most common facial features. This slide shows a schematic of the KAT6A gene. And I wanted to just mention that the different types of mutations that can occur. And so individuals with KAT6A syndrome have mutations that result in one copy of the KAT6A gene not functioning properly, but the other copy functions just fine, as I mentioned before. And so this kind of colorful schematic is a schematic of KAT6A, and where the different mutations that have been described are located within the gene. Those on top are cases from the Kennedy et al. Paper, and those on the bottom are previously reported cases. And then the numbers in parentheses are the number of individuals that have that particular change in the DNA or mutation. Those in red are missense changes. So those changes are the ones I talked about that are sort of like spelling mistakes, a little spelling mistake in the code that prevents the gene from functioning properly. And the ones indicated in black are what some have referred to as these protein truncating changes. Some other people can call them frame shifts. Some of these are nonsense changes. But what this means is that there's either an extra base of the DNA code or a missing base of the DNA code, or change that causes the gene to stop being made, a nonsense change. And all of those changes can either lead to either that copy of the gene just being degraded in the cell, or it can be shorter than expected and have what we would call a dominant negative effect. But in both cases, the gene would not be functional. And it has been suggested that depending on where these types of changes are in the gene might have some impact on the features that are present. And what I mean by that is shown on the next slide. This is a graph from the Kennedy et al. Paper. And what it shows here on the y-axis is the % of individuals. And then on the x-axis, we see the different features. So microcephaly or small head size, hypotonia, thin upper lip, feeding difficulties, reflux, constipation, congenital heart defects, and frequent infections. And the darker gray indicates when that feature is present, and the lighter gray indicates when that feature is absent. And the early versus late is telling us either there's a mutation early in the gene or late in the gene. And what you can see is that often when there's a mutation late in the gene, some of these particular features tend to be present more often. So the small head size, the neonatal hypotonia or low muscle tone, thin upper lip, feeding difficulties, reflux, constipation, so the GI findings, the congenital heart defects, and the frequent infections. And that's sort of a trend, but not something that is true in all cases. So what do we do for individuals with KAT6A syndrome? So very important that these individuals are recognized as early as possible so that early intervention and educational supports can be put into place, which Dr. Harris will probably talk more about. In particular, because they have significant speech delay, sign language and communication aids may be needed. We always do an echocardiogram at diagnosis to make sure there's no congenital heart defect that we don't know about. We recommend regular eye exams for individuals with KAT6A syndrome to identify those eye findings that I mentioned. We recommend symptomatic treatment of GI manifestations. So if they have reflux, you can treat them with medication. If they have constipation, you can treat them with diet or medication, those sorts of things. If individuals have recurrent infections, we would consider doing an immunology workup to look for some sort of immune deficiency. If there's any concern about sleep, like signs of obstructive sleep apnea, like snoring, or if they're unable to fall asleep at night, these are things that would suggest a problem with sleep, and there are certain things that we could do for that. So if there's any concern for obstructive sleep apnea, getting a sleep study, if there's sleep dysfunction and unable to go to sleep, considering something like melatonin to help with sleep. We often get an abdominal ultrasound at diagnosis, although we really are looking for any structural abnormalities in the abdomen. I didn't mention these because they're pretty rare, but we often will look just to make sure. And then we would consider a brain MRI if indicated. And we may consider audiology evaluation as well. That's like a hearing evaluation because of the speech delay. So I just wanted to mention briefly that KAT6A is one of over 82 disorders in a group of disorders that we've termed the Mendelian Disorders of the epigenetic machinery. And this wheel just shows the 70 different genes that are involved, showing here that KAT6A is one of this group of disorders. And the important thing for this is just to say that this is a growing group of genetic conditions, and what we learn, and we see many of these in our clinic, and what we learn about KAT6A syndrome may be applicable to these other disorders, and also what we learn from these other disorders may be applicable to KAT6A syndrome. So some of the similar mechanisms of disease and potentially treatments might be relevant to many of these disorders. And then I wanted to end with a slide just showing some information about our clinic. So we have an epigenetics and chromatin clinic. As I mentioned, KAT6A disorder is a disorder of, it's a genetic disorder that has epigenetic consequences. And we've seen many individuals in our clinic with this disorder. And the clinic has been there since about 2012, founded by Dr. Hans Bjornson. It became multidisciplinary in 2018. And since 2016, we've seen over 400 patients. And I would say this is some old data, so this number is higher now. And we see many different epigenetic disorders in our clinic. And if you come to clinic, you would see myself as the clinical geneticist, Dr. Harris as the pediatric neurologist and neurodevelopmental specialist, Jackie Britton as our genetic counselor, and Felicia is our clinic coordinator. And I just wanted to end by thanking you for inviting me to speak to you all tonight. And this is a photo that I actually took off of the KAT6A Foundation website because this was a photo taken at the clinic that we had in 2018. And I want to thank you all for your attention, and I look forward to the time that we will be able to get together again in person. Thank you so much.
Thank you, Dr. Fahrner. Dr. Harris, are you ready?
I am ready. Let me just get my screen sharing up. All right. So I'm going to talk a little bit more about the neurologic and neurodevelopmental manifestations of KAT6A syndrome. And hello to everybody. I see a lot of familiar faces and a lot of faces, or a few faces that are new to me. So hello to everyone. So let's start by just giving an overview of what I'm going to talk about. So I'm going to start by talking about what we know now about the neurodevelopmental manifestations of KAT6A. And then I'm going to end a little bit by talking about where do we go from here. And at that point, I'll turn it over to Dr. Smith, who's going to talk in a little bit more detail about that step of things. But we're going to talk about two different related areas. One is the neurological manifestations. So these include brain malformations, hypotonia, seizures, and movement disorders. And then the neurodevelopmental manifestations, which these include the early global developmental delay, turning into intellectual disability later, the speech and language problems, behavioral issues, and then sleep. So just to build on what Dr. Fahrner was saying earlier, just like in the other clinical features, KAT6A syndrome has commonalities as far as the neurodevelopmental profile with other similar epigenetic disorders. And it also has features that are specific and unique to KAT6A syndrome. And it's incredibly important for us as scientists to understand and think about what are the features that are common and what are the features that are different. And really to understand in very great detail, what does KAT6A look like as far as the development and behavior and neurologic manifestations, because that helps us when we get to, as Dr. Fahrner was talking about, potential treatment later on, to understand what are we looking for. So if we had a treatment that we were trying out, what would we expect the treatment to change? What would we want the treatment to change, and how would we measure that? So one thing we know about common features with other epigenetic disorders, specifically what Dr. Fahrner was talking about in one of her last slides, those Mendelian disorders of the epigenetic machinery, is intellectual disability. That is a common feature in nearly all of these kind of disorders. Hypotonia, and hypotonia that is worse in infancy and improves as they get older. What's frequently described as a happy or friendly disposition. And then I have on here behavior issues and sleep issues with question marks because really there's not enough known about what are these behavior issues in KAT6A syndrome, what specifically are the sleep issues in KAT6A syndrome, and are they the same or different as some of the behavior issues and sleep issues in other Mendelian disorders of the epigenetic machinery. And then there are some features that we know already are unique to KAT6A. So the one that's been written the most about is the expressive language and speech that is most profoundly affected of all of the different streams of development. That is not the case for all of these disorders. It is definitely the case for KAT6A. So that's one of those things that's unique, and that's one of those things that's a potential target for when we're thinking years down the line about possible treatments. The oromotor dysfunction that persists for a long time. So many of these with the low tone have oromotor dysfunction, but it seems that this problem in KAT6A persists, you know, almost throughout these kids' life, where they never are able to have the, you know, basic oromotor function, yes, like chewing and swallowing and things like that, but the oromotor function that's required for coordinated speech and things like that does not ever seem to properly develop. Many of these disorders have problems down what we call the neuroaxis, so basically the brain going down to the spinal cord and all of the bones that surround those organs. And so in some of these disorders, you see a lot of spine and vertebral abnormalities, so problems in the spinal cord and the vertebrae around them. And that is less so seen in KAT6A, whereas KAT6A, compared to the other disorders, has a bit more of craniosynostosis or skull abnormalities. And so that is unique as well. And then again, the behavior issues and sleep issues with a question mark because we just don't know at this point. So we can start by talking about the skull malformations. So again, these are really issues having to do with the bones and not the brain inside it themselves, but you can see craniosynostosis. This is reported in up to about 10% of patients. There is no specific, so as you can see in the picture, your skull has a lot of what we call sutures, or areas where the skull bones fuse together. And what craniosynostosis means is the skull bones fuse together too early, before you want them to, and it doesn't allow for proper head growth. And so certain syndromes may have a predilection for having one suture or another suture closed too early. And thus far, we don't know of that in KAT6A. It's just reported that there's craniosynostosis without any specific suture being predominant. And then, as Dr. Fahrner mentioned, about a third of patients with KAT6A have microcephaly or small heads. This seems to be a little bit more common in the nonsense mutations. So those mutations that Dr. Fahrner discussed where the protein is not made at all, versus the ones where there's the spelling error. And there are those nonsense mutations, they are often divided into two categories. One that are late in the protein and some that are early. And the microcephaly tends to be more common in the late mutations. And then again, the vertebral and spinal malformations that can be common in some of the other MDEMs are seldom reported in KAT6A. Then we go to brain malformations. So there have been many different minor malformations reported in patients. And I want to stress this word minor because anytime you hear that your child has a malformation in their brain, that sounds horrible and scary, right? But the reality is that many people who are typically developing and otherwise healthy probably walk around with some minor malformations in their brain that we don't know about because we don't get MRIs on everyone who is healthy. And so these kind of malformations that we see primarily in KAT6A don't have, as far as we know, a lot of clinical consequences, meaning the problems that you see in KAT6A are not directly related to these malformations in the brain. So things that you hear about are a thin or absent corpus callosum, or the connective center of the brain. Megacisterna magna, or Chiari-1 malformations, which is basically differences in the spacing in the back of the brain. Delayed myelination, which just means that all the cells in the brain, try to get myelinated or wrapped over time to help them carry the signal better. And in certain patients with KAT6A, it's been reported that their myelination does not happen as quickly. It does happen later, but it happens quickly. And then there have been a couple of patients with some more significant abnormalities, like one patient with a pituitary abnormality, one patient with a cortical dysplasia. But when you only have a cortical dysplasia, is a type of brain malformation that can cause seizures. But when you only have one patient out of, so many reported, you don't say then that that's a feature of the syndrome, because that could be something that just happened to that one patient randomly. And the only reason it is mentioned is because KAT6A is still to this day rare enough that there aren't enough reported to say it's not a part of the syndrome. We just don't want to say that it is. But the bottom line is there are no significant common trends in brain malformations in KAT6A. So it's not a major feature of this disorder, which is why Dr. Fahrner said sometimes we consider getting a brain MRI. If it were a major feature of the disorder, we would say, hey, all of these kids need a brain MRI. But the vast majority of the time, we don't find anything on a brain MRI that is clinically helpful. So we usually reserve those for patients in whom we see something, like a difference on one side of the body or the other, that we say we need a brain MRI to look and see if there's a difference there. Hypotonia. So hypotonia means low muscle tone. So these children are often described as flexible or clumsy. This is reported with all types of mutations. Again, most common in those late truncating mutations that we said earlier, but really pretty common throughout. It's reported in about 3/4 of patients. These muscle differences are centrally mediated. And what I mean when I say that is they come from the brain and the nerves. So there's nothing specifically wrong with the muscles themselves in KAT6A, but it's something with the brain that causes the signals to the muscles to be changed, and thus this low muscle tone. This can be quite significant in infancy. So some kids with KAT6A are described as very floppy babies. And then as the kids get older, it's still present. So, a knowledgeable examiner would be able to pick up the low tone on exam as the kids get older, but it's not really significantly impairing. So, the kids may be a little bit clumsier. They may have, not the greatest balance. They may be less likely to be, the captain of the soccer team, but almost all kids with KAT6A, again, not all, but almost all kids are functional. They walk, they run, they jump. And so the treatment, so to speak, for hypotonia is physical therapy. So this is 100% necessary for kids with KAT6A in the infant through the preschool years when the hypotonia is more significant. It really does likely help with the child being able to meet their motor milestones. And it may be beneficial later too, depending on the child and the therapist. A lot of kids with KAT6A kind of graduate out of physical therapy because it becomes less useful, but oftentimes they continue. Seizures. So seizures in KAT6A are more common than they are in the general population. So if you look at the population of all people, seizures are present at about 1 to 2%. But in KAT6A, they're present at about 10%. So that is significantly increased compared to the general population, but it is still really a very uncommon feature of KAT6A. So the vast majority of children with KAT6A syndrome do not get seizures at any point. There was one study from Spain that reported it to be more common. This was a study of 5 kids, and they said that 4 out of the 5 kids had seizures. You know, when I look at that paper, I'm a little unsure about their data and what exactly they're classifying as seizures. So that doesn't cause me to panic. I believe that the 10% number is likely where the true number lies. Seizures are reported with all different types of mutations, and there have been multiple seizure types reported with no trend. So it's not like kids with KAT6A get one specific kind of seizures or one specific localization for their seizures. It can be any kind of seizures if it happens. And then movement disorders. These are not thought to be very common in KAT6A. Some patients have what we call stereotypies or tics, so kind of repetitive movements that you might see in children with autism. And then one study reported a patient with a significantly exaggerated startle response, which is a form of a movement disorder. And this patient also had seizures. But again, back to what we were talking about, one patient, you know, you just kind of chalk that up as interesting at this point without taking any stock that that's definitely a part of the disorder. And then neurodevelopmental issues. So these are generally the primary concern of families of children with KAT6A throughout the lifetime, especially post-infancy. And this is a primary area of where our research and our clinic that Dr. Fahrner was mentioning, this is where the care is focused, because these are issues that persist throughout the lifespan of kids with KAT6A. So for early development, developmental milestones are generally universally delayed. So every stream of development you see delay. Gross motor usually does the most catching up of all the streams of development, but things like walking can be quite delayed. You can see kids who are over 3 and not walking yet. Fine motor kind of stays steadily behind throughout life. Social emotional can sometimes actually be a strength for KAT6A children. Language we're going to discuss a lot more later. Children with KAT6A often look more delayed in early childhood than they end up looking later. So in early childhood, they can look incredibly profoundly impaired, and they don't look so impaired when they're older. And this is often due to their hypotonia. So that low muscle tone that's pretty significant delays their motor development. And then the expressive language. So it's hard to look for other ways of communication in a little tiny kid who has no words. And so those kids end up looking pretty delayed when they may not be quite so impaired. Early engagement with therapies through infants and toddlers or other modalities is very important in this disorder. And again, those late truncating mutations that we talked about, they seem to be the latest to meet milestones. So they're still all delayed. They still kind of follow the same pattern, but they tend to, on average, again, each individual case is different, but on average seem to possibly meet milestones a bit later. So intellectual disability. Intellectual disability is present in 100% of reported cases of KAT6A. But intellectual disability can mean a lot of different things. So the largest proportion of kids with KAT6A fall in the moderate to severe range, and this is based on an IQ score. And the IQ score is, again, this is just trends, but tends to be the highest in those missense mutations or the spelling errors. And then the truncating mutations, their IQ scores tend to be a little bit lower, with the late truncating mutations seeming to be the lowest. And then a few kids with KAT6A still meet criteria for intellectual disability, but scatter into mild and profound. Now that said, that all of this intellectual disability diagnosis in KAT6A, at least in the literature, is based on IQ scores. And IQ scores in KAT6A may not adequately reflect children's functioning because kids with KAT6A have such a huge discrepancy between their verbal and their nonverbal skills in general. And so it is really imperative for all kids with KAT6A to get good neuropsychological testing and have good developmental follow-up, and to share these things with the school for an IEP. Because again, an IQ score, just one full-scale IQ score, is really not going to describe a kid with KAT6A because the discrepancies are so significant. The other thing that's important to note is intellectual disability is actually something that should be diagnosed based on two things: an IQ score, but also something called adaptive functioning, or how does the child function in their environment. And there is no published data at all about adaptive functioning in KAT6A. We don't know. And so this is something that's incredibly important to know about, because we're missing half of the story for intellectual disability. This chart down here just shows kind of the differences between the different kinds of mutations for specifically developmental milestones and intellectual disability, and that is based on the Kennedy et al. Paper from 2019. But again, these are very broad measures. These do not talk about the specific strengths and weaknesses within cognitive profiles. These don't talk about adaptive functionings. These are very, very broad strokes to talk about cognitive functioning in KAT6A, and we need to do better. So, speech and language. Language is the most affected area in the majority of children and adults. 100% of reported individuals with KAT6A have problems with speech and language. There's a huge discrepancy between verbal and nonverbal scores if you were to look at any sort of cognitive testing. And there's also a huge discrepancy between expressive and receptive language. So what does that mean? That means that what the testing shows, and what most families, I think, on this call would tell you, is that there's a huge difference between what their child with KAT6A knows and understands as far as language and what they can express. It is really important to note, because this can sometimes be a little bit unclear in the literature, and that is that from what we know, the affected area in KAT6A is both speech and language. So there's a problem with speech production, right? There's a problem with coordinating the muscles of the mouth and throat and everything else to make speech. But there is also a problem with expressive language. So expressive language problems go beyond that. So kids with KAT6A may be impaired even in written language, in signing, and all sorts of other ways of expressing language that go beyond speech, even though their receptive language may be much more intact. And so that is important to know and understand for helping these kids to get some sort of communication as best as possible. And early investigation, in my opinion, early investigation into assistive technology for communication is very important. So, there are some therapists and other people who will say that you should not introduce assistive technology early, because then the child is not inclined to want to use words to speak. And I first of all want to say that there isn't any data that that's even the case ever. And second of all, I want to say that we know that in KAT6A syndrome, that expressive language is extremely impaired. And so, those words may not develop, even if the kid has a lot of cognitive strengths. And so it's important to give them all of the options to communicate that are available. Behavioral issues. So children with KAT6A are generally described as happy and social. But 40% of these children are reported to have behavioral issues. What does that mean, you ask? Well, I don't know, right? That's all that we have. We have these words, behavioral issues, which kind of mean nothing, right? So there isn't a lot of specificity about what these are. We don't know if it correlates with their level of intellectual disability. We know about a fourth to a third have been diagnosed as autistic, but we don't know anything more than that. So a lot of people can be diagnosed with autism for a lot of different reasons, and there's a lot more to it than just saying those words. So it's important to know what sorts of behaviors are you seeing, how are these behaviors manifesting, how are they correlating with other features, is there any genotype-phenotype correlation? All of that is unknown, and we absolutely need better information about this. And then sleep dysfunction. So as Dr. Fahrner mentioned, all types of sleep problems, so both behavioral sleep problems and obstructive sleep apnea, are more common than in the general population. They're reported in about 30 to 40% of patients. It's, again, back to, we absolutely need better information about this. It's unclear if this correlates with other clinical or neurodevelopmental features. It's unclear what types of sleep problems, especially when you're talking about the non-OSA or the non-obstructive sleep apnea. What type of sleep problems are these kids having? What are their manifestations? How do they correlate with their other features? Not known. We need better information about this also. And so where do we go from here? So right now, KAT6A is a new and rare disorder, and so we need more research in every area. So cell models, animal models, clinical research, all of these need more research, and there are many really good researchers at different places doing this sort of research in KAT6A, or at least starting to. And so here, as I said, we're very interested in the neurology and neurodevelopmental features of these kinds of disorders, and specifically KAT6A. And so we have an ongoing study in these neurodevelopmental neurobehavioral phenotypes that is running. Dr. Clay Smith, who is a child neurology and neurodevelopmental disabilities fellow who will shortly be graduating, has been kind of piloting this study with myself and Dr. Fahrner. And so with your permission, I'm going to turn it over now to Dr. Smith, who's going to tell you a little bit more about this. And here are the references that I used for this talk. All right. Thanks, everyone.
Thank you, Dr. Harris. Thank you, Dr. Fahrner. I won't keep you long. I know it's getting late for folks on the East Coast, and I won't expound much about why the research into behavior and sleep and better describing the behavioral phenotype of patients with KAT6A is, but more of the how. Initially, we were hoping to have the group meet in person here in Baltimore, and we were going to do some investigation into cognition and language, like Dr. Harrison mentioned. But of course, with the pandemic, we've had to pivot. And so there are a few tools. There's a battery of tools that we've selected to try to better assess several things. So there are 4 total caregiver reported inventories. The first one may focus in adaptive functions, so practical everyday life. How are the patients meeting environmental demands, self-care, interacting with others, and then we're looking at behavior. So there's a checklist for behavior. Is there anxiety, attention issues, things like that, behavioral and emotional components? And the other part, sort of the opposite end of that, are there, how are the positive affectation in these patients? And then the last part is sleep. So looking at sort of a litany of different sleep things. Is there delayed time getting to sleep? Is there issue with sleep maintenance? Is there issue with obstructive sleep apnea or snoring, restless limbs, things like that? And when we're able to sort of get that behavioral and functional pattern, it helps to correlate that with things that we found like IQ that Dr. Harris mentioned. There's potentially a discrepancy there, and so we'd like to learn more about it. Sort of how are IQ measures rating versus adaptive measures, and is there a difference there? But I don't have any slides, obviously, but I want to share with you guys, if I can here, my email. I don't know if you guys can see it. Is my email up there? Thumbs up from Dr. Harris. Perfect. So my email is smithcl@kennedykrieger.org. If anyone has any interest, feel free to shoot me an email. I think probably about 20 to 25% of you have already reached out, and I want to thank you all. And I want to thank Dr. Esper for putting this together tonight. Thank you all for your time.
And Dr. Smith, you'd say it takes about 40 minutes total?
Yeah, so there's potentially a little range. There may be 15 to 20 minutes for each tool. So I'd say that if you wanted to do it all in one sitting, that's great, but I wouldn't fault you for having a little questionnaire fatigue and choosing to do one on each day.